I'm Rob Koenekoop. I'm a pediatric ophthalmologist and a specialist in inherited retinal degenerations. And I work at the Montreal Children's Hospital, and that's in Montreal at McGill University. Now, my practice is partly academic and partly in private practice. Most of my patients are children and babies, complicated babies, complicated children, but also just regular pediatric ophthalmology. And then every day I see patients with inherited retinal degenerations, at least 2 to 3 per day, maybe 10, 15 per week. So these are children, young adults, and adults with retinitis pigmentosa, with Leber congenital maurosis, and other complicated retinal diseases. I use the RETeval every day. It's very easy to use. And I don't use a technician to use it. I like it so much that I use it myself. So if I need an ERG, I'll do it right away. So, and that is something that I hadn't imagined, because we're all taught with ERGs that you have to book them, then you have to prepare them, and then the testing takes a couple hours, and then the reporting takes a couple of days. But within, I don't know, 5-10 minutes, I can have an ERG done. We use these special goggles, and we put the child or the adult in the waiting room so they can talk to their family, or they can listen to music. And then, of course, the RETeval is a tiny instrument. It's gorgeous. I have it in my backpack sometimes. Remember that these patients are complicated. Imagine doing a workup on a patient who's going blind and crying, and then not knowing the diagnosis on that day because you can't do all the testing. So with the RETeval on the same day, the OCT, and then genetic testing in a few days or weeks, I know what the child has before they leave the office. So I feel that I'm better because I can do everything on the same day. If I had to go back a week later or 2 weeks later, I would have forgotten some of the subtleties of a child. So that is amazing that I can do it in between patients. I have not seen less patients. I've done 45 RETevals in the last few months in very, very busy pediatric clinics. There's many protocols, at least 40 or 50. And so I'm exploring all of them, and they're very interesting. Cone ERGs, rod ERGs, there's the photopic flash, there's ganglion cell function, there's the VEPs. I've used all those, but my favorite really is the dark adapted rod flash followed by light adapted flicker. I can do that within 4 minutes. And then the report I could show the parents. There's nothing more fun than a child who doesn't see normally to have a normal ERG. And the parents understand the power of those waves. So that's one of the things that I'm learning, is that there's a lot of children who don't fix that well. They have nystagmus, and they could just be delayed, or they could just have a benign nystagmus. But it's very important to the parents and to me to rule out the terrible congenital diseases that cause blindness. And so the RETeval has been very helpful in identifying those patients that are normal. It's very good for drug toxicity. I have a lot of patients on vigabatrin who are in wheelchairs, who could never put their face into the regular ERG, into the dome. But I go with mom to the wheelchair, and we play together, and the electrodes are amazing. They're like stickers. I use them as stickers. I said, let's play a game with stickers. I put a couple of stickers on their hands, and then I put the electrodes on their face. In the 45 ERGs that I've done so far, I haven't failed in a single child yet. There's not been a child that didn't allow me to finish the protocol. So I get referrals from my colleagues, and they will ask me, can you go to the ICU, the neonatal ICU, or can you go to the operating room? I have a child asleep. Can I ask you to do the RETeval? So that's something that we never were able to do. We never had an ERG machine in the ICUs or in the operating room. So that's something completely new for me. I was asked a few weeks ago to do a child in dialysis. She was losing vision, And we did a VEP in the dialysis unit in 10 minutes. Here, where I work in my clinic, I will either have a referral from a colleague with nystagmus and low vision, and I'll just do it as part of the workup. So I will take the vision, as I do in all children, take the history, put the drops in, dilate the pupils, dark adapt in the waiting room. Babies can be dark adapted. And then mom comes with the baby in the room. I turn the lights off. I have an alligator lamp, a reptile red light. All the lights are out, and then we start playing. And then within a few minutes, I have an idea if the rod function is normal. And then I do the cone function. And then in an older child, I'll do an OCT imaging of the retina, autofluorescence, retinal camera, and then I go over everything with the reporting. So the number one thing is that I would say that everyone should use the goggles and not use technician's time sitting in a dark room. Put the patient in the waiting room with music and the goggles. I find that I'm getting good rod readings after 20 minutes of dark adaptation. If you're concerned, you could use 30 minutes. So that's tip number one. Tip number two is in the young children, have the child sit on the lap of the mom and put the chair quite high so the child doesn't feel intimidated, and start playing a game. Like every other testing in children is games also. Visual acuity is a game. Prisms is a game. Measurements, strabismus. So the RETeval fits right in. It's a game, and it's fast. And then read up on the different protocols. Start simple, because some of the ICEF standard protocols are excellent, but they take a bit longer. I find that if I can get the answer with a very simple rod and then cone test, I'm very satisfied. And for drug toxicity testing, it's also very, very good. I haven't used the photo negative flash yet to assess ganglion cell function, but I'm going to tell my glaucoma colleagues, especially in pediatrics, that this is something very exciting. And you just updated it as well. And then finally, I think that for all orbital tumors and all visual pathway tumors, the VEP is outstanding to tell you if there is compression or if there is involvement of the tumor with the visual system. And I find it very easy to use also.